Hello class. The first thing I want to do is go over the medications that I hope you will be able to learn and understand for week 1. I'm just going to start with the insulins. The first one is regular insulin. And as I said in class on the first day, it's very important that you understand what the therapeutic classification is, as well as the pharmacological classification. And with regular insulin, it is an anti-diabetic drug serving as the therapeutic classification. And for pharmacological classification, it's a short-acting hypoglycemic drug. As I mentioned in class, the chart for all these insulins is in your Adams Pharmacology book on page 1118. And what's important to know and understand is to look at each of these insulins and know the onset, the peak, and the duration. Because knowing that can alert you to when your patient would possibly experience some type of hypoglycemia, and that would be most likely to occur during the peak action of these insulins. So just a little bit of information to help you understand and to process when you give these insulins. And as I said, sometimes your patients, depending on how difficult it is for you to control their blood sugars, may be on 2 or 3 different types of insulin. Remember, we can classify these insulins as to whether or not they're a basal insulin or a prandial insulin. And what we mean by that is, with a basal insulin, we would give that in the morning, more of your NPH insulins to hopefully spread that effect out throughout the whole day to provide your patient with a more controlled blood sugar. Your prandial insulin, such as regular, which I'm going to talk about in just a minute, is what you would cover your patient according to sliding scales. And another type of insulin, too, that we give with a sliding scale is your very rapid acting, your Novolog. So I'll talk to you about both of those, because those are the 2 types of insulin you're going to see the healthcare provider order as a means to provide insulin for your patient's sliding scales. And obviously, I'm sure you're going to find out now that you are in the clinical area for acute type patients, we'll do an AccuCheck and before the patient's meal comes, and also in the morning before even you give your basal insulins, just to determine what your patient's blood sugar is at the time. Always advisable never to give your patient insulin until you absolutely are sure of what your patient's blood sugar is at that time, because we need to be sure that we're not going to put our patients in any danger of causing them to develop hypoglycemia. And if our patient's blood sugar would be too high, we might want to call the physician and include more insulin, or maybe having the physician order an additional type of insulin just to get that blood sugar down. Now, a lot of times you will be alerted as to what your patient's blood sugar may be by just how your patient exhibits manifestations of either hypoglycemia or hyperglycemia. And that's why, as nurses and patients themselves, should recognize signs and symptoms that their blood sugar is falling. And some of them happen early, and then as they continue to manifest, where additional sugar or calories are not provided, the blood sugar can continue to fall, putting your patient in a very dangerous situation. The same goes with hyperglycemia, because we always worry about a patient who is a known diabetic to reach very serious levels, high levels of blood glucose, which could put them at risk for going into what we call diabetic ketoacidosis, or commonly known as DKA. And you'll learn more about these emergency situations that can occur with your patients in your lecture. But for now, I'm just kind of prefacing just the important things we as nurses need to understand about our patients' diabetes, because you will find that not all patients are controlled in the same way, because everybody who has diabetes manifests the disease in a different way, and may respond differently to certain amounts of insulin, and may be very well controlled on one type of insulin, along with their diet and exercise and other activities, which definitely affect their blood glucose. So, and again, insulin needs to be taken very seriously. And to show how the administration of insulin is a very serious medication, we pretty much label it as one of those high alert medications. So when you draw up that insulin and you're about to administer it to your patient, I think now all acute care settings are requiring a second RN to check and verify that the type of insulin as well as the dosage are correct, and we'll have to co-sign that in the electronic medical records in the EMR. So I think that's a very good thing, because it's about safety and being sure that we are administer not just the right dosage, but also the right insulin, because that's very important. And so it's also necessary as nurses that when we have that nurse check that we bring the bottle of where we extracted that insulin from, so she knows that it is the correct insulin. And it's important too to know the facility in which you are caring for your patients, to know how that insulin is being stored. Usually once insulin's opened, it should be dated, and usually it's only good for about 30 days. But please check with your pharmacist in the hospital as to what policy they're following in regards to their insulin. So from that, let me begin and talk a little bit about regular insulin. This is the type of insulin that we would use to treat our patients if they went into DKA. Insulin works in about 30 to 60 minutes, and obviously the goal of regular insulin is to maintain blood glucoses within normal limits. It peaks at about 2 to 4 hours, and it lasts for about 5 to 7 hours. And this is the only type of insulin that we can give IV. When we are providing insulin to our patients, the route of administration is subcutaneously. So I'm not going to get into how that is administered. Hopefully in lab you will learn about the proper procedure in administering a sub-Q injection to your patients. The mechanism of action is really identical to endogenous insulin. It's obviously given to your patient to help decrease their blood glucose by increasing cellular uptake of glucose and stimulating storage of glucose as glycogen. What's also important to understand is when we administer insulin to our patient, it's very important that physicians kind of look at this insulin as trying to mimic how the action of the pancreas would work, and we're kind of doing it from outside sources such as the insulin that you're going to give your patient. Now, it makes sense that when we talk about adverse reactions or food interactions with a medication such as regular insulin, obviously the big side effect is hypoglycemia, because obviously our intent is to bring down that blood sugar, and obviously it could cause your patient's blood sugar to get lower than what we would want it to. So that is obviously something that we would watch for, and that's why, again, it's so important to understand onset, peak, and duration. Okay. So I would think that would be pretty much, what we would look out for. And then think about, too, if my patient does develop hypoglycemia, where I have a blood sugar that is lower than I desire it to be, also be aware of what the protocol is in your particular acute care setting as to what would I do if my patient's blood sugar falls to very dangerous levels. I know Cleveland Clinic, all their hospitals have a specific protocol on board, and so it's very important that we follow that. The old way to provide sugar to our patients when their blood sugars fall was we used to give some orange juice, and we'd put a couple packets of sugar in that. And I'm not saying it didn't help increase their blood sugar, but it could also have been a very dangerous situation, because we know with orange juice has potassium, and sometimes we have to be very careful about that, because some of our patients not only have diabetes but may also have some renal issues, and we sure don't want to impose a large amount of potassium into their system and cause them to become hyperkalemic. So just be aware of what the protocol would be. Most of the times we might give a short-acting carbohydrate, may give dextrose. If your patient is alert and oriented, that surely makes a difference as to how you're going to provide a supplement to get that blood sugar up. If they're lethargic and comatose, obviously we are not going to have the patient take anything orally for fear of aspiration. So many times we might have to give a glucagon injection, or also a IV dextrose 50% to get that blood sugar up fast. The only problem with glucagon injections are it takes a little bit of time to work. Patients usually go home with that. They're taught how to give injections. So are the family members, in case their blood sugars get low and they're able to give it to themselves. But with an IM glucagon, it takes usually 15-20 minutes for that drug to go into effect. So it may be a little while before that blood sugar comes up. So that's all I'm going to really say about regular insulin. Also, just be sure that we're aware of our patients' medical history. How long have they had diabetes? I kind of like to get a feel of how their blood sugars have been running in the last 2 or 3 days. Make sure that you're providing that injection site where it should be, assessing injection sites, and just kind of asking your patient about his present knowledge on his diabetes in regards to diet, and if he's aware of what he would do if his blood sugar went too high or too low, and does he kind of feel when those things are coming on. So that's regular insulin. The next one we're going to talk about is NPH. It is the only intermediated insulin. Onset is about 1 to 2 hours, peak is in about 4 to 12 hours, and your duration is about 18 to 24 hours. And another thing that you need to know is when you look at these insulins in their particular vials, should it be clear or should it be cloudy? Regular insulin is a clear insulin, but with NPH, it's a cloudy insulin, and that is what it should be, and that's very important. And obviously, before we draw up these insulins, always look at your vials, inspect the insulin inside those vials to make sure there's no funny looking particles in there, that it is the clarity that it should be, and then follow the proper procedure to extract that insulin from that vial. As far as therapeutic and pharmacological classifications, again, on anti-diabetic drug as well as a intermittent insulin, which is what NPH insulin is. This is one of those insulins where we'll check their blood sugar in the morning, say if we're working the day shift, and assess what that blood glucose is, and as long as your patients are eating, we would give this NPH insulin before meals, and then of course cover them according to a sliding scale if those patients would also be on that too. So it would not be unusual to give an NPH insulin and then cover your patient with either regular insulin or Humalog for a sliding scale. Sometimes you might see NPH given in the morning, and sometimes you might see a small second dose given in the evening, just depending on how we're able to control your patient's blood sugars. Okay. Again, always assessing their blood sugar and looking for signs and symptoms of, hypoglycemia. Okay, so that's pretty much about NPH insulin. Okay, if you're mixing clear and cloudy, obviously since it's a cloudy insulin, it should be drawn up last. Okay. The next insulin is insulin aspart or Novolog. This is more of a rapid onset, more than regular. The onset can be from anywhere to 5 to 15 minutes. Peak occurs in about 1 to 3 hours, and duration is only 3 to 5 hours. The important thing to remember with this is, since it is an insulin that we use for our sliding scales, since the action or the onset is very quick, I really suggest that you wait until your patient's trays are up and that they're beginning to eat, because if they would be delayed and you've already given the insulin, the Novolog, your patients could see changes in their blood sugar occur without them eating, and their blood sugars could drop very quickly. So that's my only advice on that. The other kind of insulin, just so you're not confused, is your Lispro, which is also a Humalog type of insulin. That is also one of those very rapid onsets. So you might see those two types of insulin ordered with your sliding scales. So those are 3 of the insulins that I would like you to kind of look at and understand. You will see these again, and with you studying diabetes in your lecture with Nursing 122, it's really important that you really know these onsets, peak, and duration of your insulins, and be aware of protocol in your hospitals with what to do if your patients would either have too high or too low of blood glucose, and also what is the policy of how we store insulin, and being sure that you are checking your insulins with another registered nurse to verify accuracy with dosage as well as the correct type of insulin that you are administering. Okay. The next drug I want to talk about is heparin, and therapeutically it's a anticoagulant, and pharmacologically it's an indirect thrombin inhibitor. It's an antithrombin med. And this, again, along with insulin, is another one of those high alert medications. I'm sure you've heard of heparin. Some of you may have given it to your patients. It can be given sub-Q or IV. We use it to treat DVTs, which are deep vein thrombosis, pulmonary emboli, myocardial infarctions. We may give it to our patients who have unstable angina. You'll learn about the term STEMI versus non-STEMI. It helps to prevent thrombosis in high-risk patients. And how heparin works is it activates the enzyme antithrombin 3, which in turn inhibits thrombin. It also activates factor 5. Before your patients would receive, say, for instance, begin like a heparin protocol due to some of these diagnoses that you would see happen, it's very important that we get a coagulation panel, and we just kind of look at that baseline of PTT, platelets, things like that, that give us an idea what the patient is presently at before we begin heparin therapy. Now, many times, if not all the time, when your patients come into an acute care setting because of their decreased mobility, their present diagnosis of why they came to the hospital, many of them are put on heparin sub-Q, 5,000 units every 12 hours, just to prevent any, DVTs or any problems with thrombus. But many times when our patients are ordered higher doses of heparin, such as a heparin protocol, we really want to make sure we're assessing those platelets and looking for a problem that can arise called HIT, or heparin-induced thrombocytopenia. That can appear about 5 to 10 days after beginning heparin. And what we see with that is, and a thrombocyte is basically another name for a platelet, and when we talk about thrombocytopenia, that suffix on the end of that word refers to a low count of platelets. So that's what we want to make sure that your patient isn't developing HIT, which could severely deplete your patient's platelets, which obviously puts them more at risk for bleeding. So heparin's been a drug around for a long, long time. Some of the physicians are still ordering heparin protocol. Not many, because we do have such new meds as Lovenox. And with heparin therapy, the patient has a continuous IV. We're checking PTTs every 6 hours, and we are constantly making adjustments. And it's kind of an inconvenience to the patient to have this IV. And you as the nurse need to constantly assess to make sure that that heparin is not, removed from the patient, or accidentally gets pulled out, or is disconnected, or interrupted in any way, because we want to keep that PTT at a certain therapeutic level. So that's why it's much more convenient to go ahead and give these other medications. But we still use it. It's still the med that we use prophylactically for our patients, and to treat some of these very serious issues, as I said, such as DVT, PE, and MI. But that's why it's important to be sure to look at that baseline coagulation study or panel, and then just to continuously assess your patients for any serious adverse reactions such as HIT. It can also cause osteoporosis in prolonged uses, may cause skin lesions, and obviously if your patient has any signs of bleeding, you would not further administer this or even start it. If by some chance you would get that baseline blood work on your patient, and you would see that the platelet count are below 100,000, then we would not start heparin on that. When your patients are on these anticoagulants such as heparin, be very careful with IV sticks, even IM injections, anything that's invasive, because your patient could bleed at that site. Some of the big bleeds that we watch for, especially in the elderly, are the GI tract, of course, looking for tarry stools, coffee ground emesis, and then neurologically looking at any signs of some type of cerebral bleed, because these are the things that we most commonly see in our patients who are elderly that might have very fragile vessels. So heparin may at one point help whatever is the reason that your family your physician has ordered it, but it also can be very detrimental to your patient to cause some serious bleeds. So it's just important to be on the lookout for that. It's also important to know what the overdose, kind of like the what's the word I'm trying to look for? If they do have an overdose or start to bleed, the antidote, that's the word I'm looking for, is to give protamine sulfate. I always like to look as to how the medication is given, so if there is a time when your patient would start bleeding, I'm aware of exactly how I'm going to administer protamine sulfate and how fast to administer it. Obviously, the labs that we look at when our patients are on the protocol of heparin is your lab value of a PTT, okay? So again, looking for signs of bleeding, checking urine, checking stools, monitor labs. Even if you're giving the sub-Q injection, be sure that you watch the sites for unusual bruising, redness, swelling, or signs of infection. Please be aware of your patient's blood pressure, because that could indicate that there could be some bleeding going on. Use cautiously in your patients who have renal or any hepatic problems, because they can raise labs to toxic levels. Watch some of your patients who have been on some kind of herbals, especially ginger, garlic, green tea, and ginkgo. These could increase the risk of bleeding for your patients. So that's a bit about enough information to understand about heparin. If you know that, you're going to be fine. The next one is just some of these, for instance, your TB test, which you're very familiar with. It's on page 850 in your book. Therapeutically, it's a purified protein derivative, a PPD, used for diagnosing TB or exposure to TB. It's also referred to as the man-tooth tuberculin skin test. If you have a positive test, it indicates the presence of memory T cells to your tuberculosis, but it really doesn't mean that you have an active case. That's where if you do have an induration noted on your arm after 72 hours after you receive the test, then it just may mean that you're exposed. So at that point, it would be suggested to have a chest x-ray. Once positive, always positive. It's given transdermally and read 48 to 72 hours later. Positive will show reddened skin. I myself have a little reaction to the medication, but I do not have an induration occur. But like I said, if it does show a positive result, it will be advised for you to have a chest x-ray, sputum, and some additional lab work. They'll look at your medical history as well as recent travel. Okay. The next one is morphine. This is talked about in your book on page 376. It's a narcotic analgesic, and pharmacologically it's an opiate agonist. We give morphine for acute and severe pain. This is probably one of the best choices, if not the choice we use when our patients are having an acute MI or acute myocardial infarction. Sometimes we also give this as a pre-anesthetic sedation, calms agitated patients down. Plus, I think we use this too in some of our terminally ill patients who have cancer, who have severe pain from their tumors or their cancer. We might also use it with respiratory distress, sometimes with pulmonary edema. They also might use it for epidural injections for post-surgical pain. The important thing to remember with this is being aware that this is a very potent opioid, and it can cause severe respiratory depression and severe central nervous system depression. So just be sure that you assess your patient well, because sometimes you can see the CNS effects, such as dizziness, anxiety, sedation, confusion, hallucinations, and sometimes even seizures. And with respiratory depression, obviously you're going to see increased CO2 levels, which could really change the level of consciousness for your patients. People that take this, maybe over a period of time after some very complex surgery may develop, opiate-induced constipation. So you want to be aware of that. Obviously, when you're on some type of opiate, you should not be taking ETOH, any skeletal muscle relaxants. Really be very cautious when we're using morphine in the elderly, anybody who has undiagnosed abdominal pain, looking at your patient's renal and hepatic function, and just be aware of the effect it can have on the central nervous system. Check blood pressure, vital signs, get a baseline before administering weight and height, so make sure that you're giving a proper dose, not too much, especially on the elderly. Assess pain, location, intensity, and character prior to giving the medication, and then reassess to see how it has relieved the patient's pain. Again, as I said, since it can cause opiate constipation, assess bowel signs and functions for constipation. So if that occurs, again, intervening with high uptake of fiber, stool softeners, and things like that. The big thing is obviously CNS depression, looking at your patient's level of consciousness, any respiratory depression, hypotension, and confusion that can occur. Sometimes this can make a person very nauseous too. So if a person is very sensitive to these kinds of meds, it might be a good thing to give nausea meds 30 to 60 minutes prior to taking some type of an opiate like morphine sulfate. You can give this medication IV push along with, and that's probably the best route to give it to get the maximum effect desired for your patient. All right, and then I'm just going to talk briefly about the flu and the pneumonia vaccine. Obviously, those are recommended to our patients who are at high risk to develop those, the elderly, people with chronic diseases. As far as the flu, it's a vaccine, helps protect the body against flu, prepared with portions of the most likely type A and B flu. There is a nasal form. We're probably more familiar with the injection, which is usually given IM in the deltoid. Assess egg and mercury allergies. Really, some of the side effects we might see is fever, chills, and muscle aches, flu-like symptoms that last about 1 or 2 days. Just important to know our patient's allergies, assess vital signs, and be sure that the patient isn't sick when they are receiving this vaccine, like they don't have a fever. Warn the patient when they do get this injection that their arm may be sore for a couple days after. So important for them to know so they don't think something is wrong. The same goes for the pneumonia vaccine. It helps protect the body against pneumonia, derived from cell walls of 23 strains of the pneumonia bacteria. Usually recommended for people 65 or older, or who have chronic illnesses, or who are immunocompromised with such things as HIV, leukemia, lymphoma, Hodgkin's, multiple myeloma, or anybody who's had a transplant, or who's also on high doses of corticosteroids. Usually a booster every 5 years is recommended. With the flu vaccine, we get that on a yearly basis. Okay, so that is just a little recap of the insulins and other medications, and now we're going to talk about the medications that correlate with your lecture content referring to patients that have asthma and patients that have COPD. It's also a good thing to kind of review some of your physiology of the lower respiratory tract in regards to the alveoli, which are those microscopic sacs at the end of the bronchial trees that inflate during inspiration. They're very rich in capillaries, and this is where the diffusion of gases takes place, allowing the exchange of oxygen and carbon dioxide between blood and inspired air via that thin membrane. And then think about your bronchioles. Those are those muscular elastic tubes leading from outside to the alveoli. And in regards to the nervous system, which controls ventilation by changing diameter of the bronchioles, think about how the sympathetic nervous system works, causes those bronchial muscles to relax and bronchial dilatation to occur, whereas the parasympathetic nervous system causes bronchial muscles to contract and bronchial constriction to occur. And this is where that narrowing occurs, causing your patients to develop what we call a bronchospasm, okay? And with that bronchospasm is that pathology of bronchoconstriction, okay? And this is where it is a common indication for pharmacotherapy with these pulmonary diseases. Because with that bronchospasm, there's a sudden contraction of smooth muscles that causes your patients then to experience acute dyspnea or shortness of breath. And there's going to be the drugs that I'm going to talk about that actually target and to relax that smooth muscle. And along with the bronchial constriction, you also have thick viscous secretions occur, and this is very serious because some of these secretions can get so bad that they actually block the airway. So we're going to talk about some meds that may be prescribed, such as mucolytics, to help with that, with those secretions. And then along with the bronchospasms, we have edema. And with edema, that's caused by engorgement of your pulmonary blood vessels. And again, we're going to look at some of the medications that can help provide some relief for that edema in those bronchioles. So with this said, let's kind of talk about the medications that help with some of these mechanisms and manifestations that occur when our patients have these respiratory problems. All right, the first medication I want to talk about is albuterol. This is probably one of the most popular medications that we give to our patients to relieve and to help prevent bronchospasms, okay? Someone that has asthma will use this type of medication. Therapeutically, it's a bronchodilator, and as I just explained to you, the pathology that occurs when these exacerbations of these diseases occur, it makes sense that we would give a drug to help dilate or open up those bronchioles to help relieve that acute dyspnea. Pharmacologically, it's a beta-2 adrenergic medication. The discussion of this medication is found in your book on page 736 to 737. It helps to obviously relieve and prevent bronchospasms, to treat an acute asthma attack. It helps to facilitate mucus drainage, and it inhibits the release of those inflammatory chemicals from your mast cells that cause that hyperresponsiveness to the problem. And it also helps prevent exercise-induced bronchospasms. A lot of times people, if they know that exercise is going to cause this manifestation to occur, they might, take 2 puffs on their albuterol inhaler, open up those bronchioles, and prevent those bronchospasms to happen while they're exercising. it works is it selectively binds to beta-2 adrenergic receptors of bronchial smooth muscles, causing those bronchioles to bronchial dilate, okay? The big side effects that occur with this is sometimes, your patients may complain that they get extremely tachycardic, their heart starts to race, and they feel palpitations. They can also actually experience chest pain and headaches. You want to be very cautious when you use this with patients who do have previous cardiac histories, because it can actually affect the EKG pattern, causing a person to develop prolonged QT interval and chest pain, especially if they're a known coronary artery disease patient. Use cautiously with patients who are on beta blockers, because it may induce a bronchospasm. And avoid foods with caffeine, due to the fact that sometimes people, when they take albuterol, especially in the beginning until they get acclimated to the drug, may be very shaky, may cause tremors, nervousness, and of course palpitations. With extreme overdose of the medication, you might see your patient develop dysrhythmias, hypokalemia, hyperglycemia, cardiac arrest, and death. And those are obviously extreme side effects. But when we talk about albuterol, it's very important to know that this is the prototype that I really want you to really understand, because this is the medication that your patient would use at the time of a asthma attack, okay? When patients are known asthmatics, this is the medication that they need to be sure that they have with them at all times, because if they would have an asthma attack, an acute exacerbation of their asthma where those bronchioles start to close up, start to develop those thick secretions, they need this albuterol on hand, because this will be the medication of choice to use in an acute situation, okay? So I just want to make sure that we teach our patients well about these medications, because they have to have these on hand at all times, okay? So this is the only drug that is used at the time of an acute exacerbation or an acute asthma attack that will actually provide them immediate relief from the attack, okay? Because usually it's given in inhalation form, and that medication goes right to the site of the bronchioles and obviously opens them up and allows a better passage of air to get to those alveoli, thus decreasing the shortness of breath, or alleviating the shortness of breath your patient may experience. Then the next one is ipratropium or Atrovent. It's also a bronchodilator, but it's an anticholinergic, okay? This relieves bronchospasms in asthma and COPD, helps to decrease nasal drainage in common cold, relief of rhinorrhea, excessive nasal secretions, and perianal rhinitis, where people have that year-round nasal congestion. Now, this is a medication that works by causing your patient to experience bronchodilation, but it blocks the cholinergic receptors in the bronchial smooth muscle. And this is also a med that can be given intranasally, which blocks parasympathetic receptors, thus decreasing nasal secretions in a cold. This is not one that you would give at a time when your patient is experiencing an asthma attack. This is something that we would encourage your patient maybe to take on a regular basis to build up therapeutic effects of the medication to prevent them from developing some type of acute asthma attack or a problem with their COPD. What kind of side effects we would see would be if your patient had a history of glaucoma, it could worsen the glaucoma. Because it's an anticholinergic medication, we see a lot of the effects from these anticholinergic type of drugs where you get the dry mouth, nausea, GI distress, cough, dry nasal mucosa, hoarseness, and sometimes even epitascus. Obviously, avoid of sensitivity to soybeans, peanuts, avoid an urinary obstruction, and avoid use with atropine. So that's a medication that I want you to look at. The next one is Becanase AQ. It's an anti-inflammatory. Therapeutically and pharmacologically, it's a corticosteroid. Used for asthma, nasal spray for allergic rhinitis. Think about it. Being that it's a corticosteroid, we know that if you think about the action of these classifications of medications, it's going to reduce the inflammation. Because remember I said that with these respiratory problems, there is the manifestations of hyperresponsiveness and edema, and obviously with Becanase AQ, it's going to reduce inflammation and immune responses, thus decreasing the frequency of asthma attacks. Now, if your patient would have an asthma attack, an acute episode, this would not be something you would use. The only medication you're going to use is your albuterol. But many of our patients are on these prophylactically to prevent those attacks from occurring. So think about corticosteroid toxicity, dry mouth, hoarseness, changes in taste. When they're on these corticosteroids and these inhalers, it's very important that you make sure the patient or yourself assesses the inside of the mouth, because these people that are on these types of inhalers with the corticosteroids are very much at risk for getting fungal infections of the mouth and the throat. So see if there's any lesions or anything like that developing when your patients are on these. Okay. The next one is Montelukast, or this is also known as Singular, which now we can buy over the counter. It's an agent for asthma prophylactically. It's an anti-inflammatory, and pharmacologically it's a leukotriene modifier. Now remember, these are medications that your patients will be on prophylactically so they don't have an acute asthmatic attack. They will not use these medications if they have an asthma attack. The only drug, and I'm trying to enforce this because this is asked on the test, you only use your albuterol for a time when your patient goes into an acute asthma attack. This medication, Montelukast, is a prophylaxis of persistent chronic asthma, allergic rhinitis, exercise-induced bronchospasms. Many times you'll see people put on these when they have allergies, especially in the allergy season in the spring when all the trees start budding and things like that. It prevents airway edema and inflammation by blocking leukotriene receptors in the airway. And those are the leukotriene receptors are part of that inflammatory response that brings about all that edema and mucus and things like that. So if we prevent that from occurring, then we're going to prevent that manifestation from happening. Not used with acute asthma attacks. Headache is one of the most common problems. Can be used in 12 months with older patients, and there is also a chewable and a crushable form. So that's Montelukast, or Singular. The next one is another very important drug called theophylline. It is therapeutically a bronchodilator, and the pharmacological classification is methylxanthine. And this is a medication that we can give IV or PO. And what we use this for is if a patient doesn't respond well to the anticholinergics, the long-term beta agonist medications, a lot of times we'll put these patients on theophylline. Theophylline is also a medication that when they go into what we call a status asthmaticus, they come in through the ER and they're really very unresponsive to the medications that they have at home, and those bronchioles are really closing up and your patient's in extreme respiratory rest that eventually will lead to respiratory failure. They will start them on a theophylline IV drip. It relaxes bronchial smooth muscles, helps reduce inflammation, and it's very effective in a patient that maybe goes into that extreme type of an asthma attack, because it really does help relax bronchial spasms, which helps promote bronchial dilatation. It suppresses airway responsiveness to the stimuli that help to promote bronchospasms. Again, we watch our patients with an aminophylline because it can cause tachycardia and very much an exaggerated symptoms if the patient was taking a large dose of caffeine. You know how you get when you drink lots of coffee in a day. You get shaky, and this is kind of the same effect that theophylline works also. What's also important to know is that if a patient has been on theophylline at home, maybe been on the PO form of theophylline, say they've been on an oral pill called Theodur, which is a derivative of a theophylline type medication, you might want to do a theophylline level on them. And we want them to be in a therapeutic range of 10 to 20. And because we don't want them to go into any toxic levels of theophylline toxicity, because it can really be quite stressful on the cardiac system, putting your patient at risk for dysrhythmias, hypotension, seizures, and even heart failure. And when our patients are on this medication, we really advise them to limit the amount of drinks that they intake that have caffeine, such as coffee and some of your colas like Mountain Dew and all that have caffeine in them, because this works like caffeine in the fact that it really promotes bronchial dilatation, but it can also give you some of those side effects of insomnia, headache, irritability, and shakiness and tremors. So that is what I would talk to you about with regards to that. Another medication is acetylcysteine, which therapeutically it's a mucolytic, and pharmacologically it's an amino acid. And this is just given for our patients, as I told you before. The pathology that occurs is the production of thick secretions, which can be a very big hazard, because with a lot of secretion it can also be a detriment, causing a blockage in the bronchioles and not allowing air to pass to get to the alveoli. So what acetylcysteine does, or mucomist, is it loosens thick viscous bronchial secretions. Can be used by patients with cystic fibrosis, chronic bronchitis, and other diseases that produce large amounts of secretions. It's also used for people that take Tylenol in excessive amounts, Tylenol overdose, if given IV. What it does is it breaks down the chemical structure of mucus molecules, making mucus thinner to clear by coughing. So with that said, sometimes these secretions can be extremely thick, making it very difficult for these patients who already are, tired, immunosuppressed, and it's very hard to bring up those thick secretions. So acetylcysteine will help loosen them and thin them out. Sometimes these can cause bronchospasms, nausea, vomiting, unpleasant odor, and fever. But for the most part, we see very minimal side effects with acetylcysteine or mucomist. Okay. The next one is guaifenesin or Mucinex. It's therapeutically an expectorant and pharmacologically it's an expectorant. It treats dry, non-productive cough, sometimes good with productive cough, and again reduces the thickness or viscosity of bronchial secretions, thus increasing mucus flow that can be cleared out by coughing. Okay, we should not give this to children under 6 years old. If you really take high doses of this, which very seldom do I know of people that do, it can cause, of course, nausea and vomiting and a lot of abdominal pain. This is a medication we see advertised on TV that's kind of over the counter. All right, so that pretty much wraps up the medications we use for our patients with asthma and COPD. And then just a few, a little bit of extra information is amantadine, which is an antiviral for influenza, and pharmacologically it's a viral replication. We give this to people that might be diagnosed with the flu. It reduces the duration of flu symptoms and protects against flu A. Given for 2 weeks after flu vaccine to prevent flu. Used mainly in immunocompromised healthcare workers, people in close contact with high-risk people. So that's what amantadine is. Some of the how it works is it's thought to inhibit viral replication by preventing uncoating. It may also affect assembly of new virions. And as far as side effects, maybe some CNS effects. Renal patients can build up toxicity. Used cautiously in renal and psychiatric patients. Don't take it with any type of alcohol. Other than that, there really are not a lot of serious side effects we see with these medications to give to prevent flu. And then the last one I'm going to talk about is an antiviral called Oseltamivir or Tamiflu, which is the treatment of influenza A and B. And it is an ethyl ester protodrug requiring ester hydrolysis for conversion to the active form. It's an inhibitor of influenza viruses, affecting the release of those viral particles. And it usually is started within 48 hours of the onset of flu symptoms to be effective, continued until about 2 weeks after live vaccine given. So not too many side effects, nausea, vomiting, diarrhea, more GI problems than anything. So with the Oseltamivir or Tamiflu, that's given when we start to see flu-like symptoms, and the amantadine reduces the duration of flu symptoms too. So I think the Tamiflu or the Oseltamivir is much more popular. I see patients started on that much more frequently than the other one. I'm not sure about the cost involved with either one of them, if anyone's more expensive than the other. But that pretty much wraps up the medications for week 1. Please go over them. Please understand them. I've given you charts to refer to in regards to your insulins. I think these drugs will make a little more sense when you start learning about the pathology of asthma. I gave you a little preface for that so you understand what happens to your patients. Now think about it. With asthma, we're talking about a disease process that occurs in the bronchioles, and then with COPD, the disease process or the pathology is occurring in the alveoli. Okay, so that's very important to know, and so then it makes sense when we give these medications as to where the action of those meds are going to take place. And for most part, it's about the edema, the hyperresponsiveness, preventing that inflammatory response to occur. And then, of course, the secretions are a big problem for some of our patients with respiratory diseases, because that's part of the inflammatory disease where those cells produce those excessive amounts of mucus, which is very difficult for some of these patients to cough up. and then you know how it can become, a blockage in the bronchioles, allowing or not allowing the passage of air back and forth from the alveoli. And this is where our patients get into respiratory problems and suffer from extreme dyspnea. So please let me know after you listen to this. Hopefully you'll listen to it before Tuesday. If there's any questions, send me a text. We'll have to move on to week 2 medications, but I'd be more than happy to answer any questions you may have through an email. Thank you so much, and have a great day.